Welcome everyone. My name is Jaswinder Gill. I am one of the consultant cardiologists and electrophysiologists at Guy's and St Thomas's hospitals. I was initially involved with setting up the electrophysiology unit at Guy's Hospital when I was appointed as a consultant. This subsequently moved to St Thomas's Hospital, and now we have a large and flourishing group of electrophysiologists doing high-level procedures at a large volume. I'm going to talk to you today about the Convergent hybrid ablation procedure for the treatment of persistent atrial fibrillation. I could have not done any of this work without the help and support of my colleagues, including Professor Aldo Rinaldi, Dr. Shomik Adya, my surgical colleagues, Mr. Christopher Blouth, who was instrumental in pioneering in setting up the surgical aspects of this procedure, and these have been taken over now by Mr. Paolo Bosco since Mr. Blouth retired. I'm also grateful to my fellows, including Dr. Nick Child, whose picture I do not have here, but Dr. Bradley Porter and Dr. Nilanka Manakara, who were instrumental in supporting and making this procedure possible. I'm also grateful to the support and help of our large team of technicians, nurses, radiographers, theatre ODAs, and also theatre staff, without whose help the procedure would not have been possible. Just to give you a small amount of history, we initially started doing hybrid atrial fibrillation ablation in 2010 by using AtriCure clamps, and these had a rather poor success rate in our hands, and we eventually ended up giving up this procedure. The Convergent program, however, came along in 2012, and we were the first centre in the UK to utilize this. Our success at treating these patients led to the expansion of the technique to 2 other London centres, and there are now 6 other centres practicing this nationally. We were involved in the International Converge IDE study and were the second highest recruiters for this, and the results of this study have been instrumental in the procedure being adopted in the guidelines for the treatment of atrial fibrillation. The hybrid convergent procedure involves both epicardial and endocardial ablation to try and achieve a comprehensive elimination of the atrial fibrillation substrate. It achieves transmural lesions whilst minimizing the risk of esophageal injury, which is a major problem if you are doing ablation, particularly on the posterior wall of the left atrium, using catheter techniques alone. The Convergent hybrid procedure is performed by a cardiothoracic surgeon and an electrophysiologist, and this now has been termed as a heart team. Just to describe the procedure, the patient comes to the operating theatre, and the surgeon initially either does a small incision in the abdomen or in the lower xiphisternum and puts a port either transdiaphragmatically or straight into the pericardium and accesses the posterior part of the left atrium. He is then able to put a catheter which has an insulated posterior side and an active anterior side. This allows the placement of lesions as well as recording of the atrial signals, and the surgeon will try and put lesions across the posterior wall of the atrium between the pulmonary veins and essentially eliminate this whole area from being electrically active. Following this, either at the same sitting or more frequently a month or 2 months later, the electrophysiologist will go in there and map and see what has been done by the surgeon. He will then place lesions at the anterior part of the pulmonary veins and do essentially a wide area circumferential ablation to achieve isolation of the pulmonary veins. Following this, the patient can be followed up. I want to now describe the results of the Converge IDE study. In this, 153 patients were randomized on a 2-to-1 basis to the Convergent ablation procedure versus standard catheter ablation. It was a multi-center randomized controlled study with a primary outcome of freedom from atrial fibrillation, atrial flutter, and atrial tachycardia on either no increased dose of previously failed drugs and without the addition of new antiarrhythmic therapy. The primary outcome was the 30-day, the primary safety outcome was the 30-day major adverse event rate. In 2016, the protocol was amended to include prophylactic steroids to prevent pericarditis and Dresser syndrome, which can sometimes be a problem with this procedure. These are the results of the study, and you can see here that the Convergent arm did much better than standard catheter ablation in terms of freedom from atrial fibrillation and atrial arrhythmia, and there was a 67% relative improvement in the outcome when you looked at patients off antiarrhythmic drugs or on antiarrhythmic drugs. This just summarizes the results in that freedom from atrial fibrillation, flutter or atrial tachycardia was 67.7% in the Convergent group versus 50% in the catheter group, and off antiarrhythmic drugs it was 53.5% in the Convergent group versus 32% in the catheter only group, and freedom from atrial fibrillation at 12 months was 71% in the Convergent group versus 51% in the catheter ablation group. There was a very substantial reduction in AF burden, which was greater in the Convergent arm versus the catheter arm. I want to describe a case to you of a gentleman whom we treated. Mr. CH is now a 60-year-old male who in 2010 was found to be in atrial fibrillation when he attended for a knee operation. At that stage he was started on bisoprolol and anticoagulation. In May 2011 he went on to DC cardioversion and felt better for a few days before returning to his original state. He was then sent up to St. Thomas's for review, and his main symptoms at review were shortness of breath at around 20 to 40 meters. He did not feel much in terms of palpitations. He had a BMI of 42, but he was quite a large man, and not all of this was obesity alone. But he also had a left atrium of 5.5 centimeters. In 2013, he had a standard catheter ablation involving pulmonary vein isolation. He did well for a short period of time, but reverted back into atrial fibrillation, and his symptoms continued unabated. He was then referred for surgical ablation. In 2014, the surgical part of the Convergent procedure was performed, followed by the endocardial component some 4 months later. This led him to hold sinus rhythm with an improvement in his symptoms, and he continued to do that for nearly 2 years. In 2016, however, his symptoms returned again, and ECGs at that stage showed him to be in atrial flutter, atrial tachycardia. Now had 3 years follow-up since this time, and the only arrhythmia which has been recorded are atrial ectopics, and it's felt that these are the problem as far as his symptoms are concerned, but he has otherwise held sinus rhythm. And this demonstrates a good outcome as far as maintenance of sinus rhythm is concerned in a patient who was not ideal for ablative therapy. In conclusion, catheter ablation outcomes in patients with persistent atrial fibrillation are generally rather poor. Hybrid ablation offers a solution which might actually take us further forward in terms of treating these patients. What is interesting about this procedure is that it appears to be effective in patients with adverse profiles including long-standing persistent atrial fibrillation, large left atrial size, and higher BMIs. I'm hoping that further refinements of the procedure will lead us to improved outcomes and improved selection of the patients. Thank you for your attention.